A very good morning to Dr. Norley and my fellow friends. So we are from Group EFGH and we are going to share about the advances and updates in OMOP. So I hope all of you guys are ready. So let's get into it. In this presentation, we are going to see on the chairside and laboratory investigation techniques, and we will divide them into heart tissue and vasculation, OPMD, maxillary sinus, saliva and tests, allergy and neuromuscular disorder. And we will also explain on the digital microscope and slide and scanner. So for the introduction, we will look on the definitions. The definition of investigation it is an extension of the physical examination in which tissue, blood, or other specimens are obtained from the patient and subjected to microscopic, biochemical, microbiological, or immunologic examinations. While for chairside investigation, it is a simple test and examination procedures performed at the chairside. So let's look at the type of chairside investigation for dental heart tissue. So there are two types of investigation that can be done on the dental pulp, which is the pulp sensitivity test and the pulp vitality test. So for the pulp sensitivity test, there are heat, cold, and electric, while for the pulp vitality test, there is pulse oximetry and laser Doppler flowmetry. So as we can see here, these are the tests for the pulp sensitivity test. The cold test and the EPT test is commonly used in UKM, while the heat test is less commonly used. While we are using these tests, we must be aware of the false negative and the positive result. So the first test for the pulp vitality test is the laser Doppler flowmetry, whereby it is a non-invasive electro-optical technique and it is able to measure the blood flow in very small vessels of the microvasculature of the pulp. So the next test is the pulse oximetry test, whereby it is a non-invasive oxygen saturation monitoring device. It is widely used in medical practice to record the blood oxygen saturation level compared to dentistry. Next, we will look on the investigation that is being done on dental caries, which are the tactile and visual inspection, radiograph, fiber optic transillumination, diagnodent, quantitative light-induced fluorescence, electrical conductance measurement, and also ultrasound. So for the tactile and visual inspection, we need a mouth probe and also a dental mirror, which requires good lighting and also a clean, dry teeth. Initial non-cavity caries is best viewed when the tooth is dry. Sharp probe is recommended to be used as it is able to remove plaque and biofilm, and also it is able to feel the tactile sensation of the caries lesion. Next, radiograph such as lightning is very important to detect caries which are hidden from the visual tactile examination. Digital radiograph is as good as conventional radiograph. Next, the fiber optic transillumination, or also known as POTI, it uses light transmission through the tooth. So demineralized enamel will scatter the light and absorb more light than the sound tissue, so which will result in the caries lesion to appear darker than the sound enamel. Next, diagnodent is a pain-like probe which sends safe painless beam into the tooth, and in the presence of decay there will be an acoustic signal and also a digital display. Next, the quantitative light-induced fluorescence technology. It measures the refractive index between the sound enamel and the porous demineralized enamel. Areas of caries and demineralized enamel shows less fluorescence. So next is the electrical conductance measurements. It uses the concept of measuring the electrical current conductance in teeth. The porous and demineralized enamel are more conductive, while the demineralized sites in enamel can be detected as it contains high pore volume and high concentration of electrolytes. Next, ultrasound. It uses sound wave passed through the enamel. Porous and cavitated enamel will reflect the waves differently compared to enamel with normal thickness. So image of tissue can be acquired by collecting the reflected sound wave produced from the tooth structure. These are some of the investigations, chairside investigations that can be done on cracked tooth. First is for thigh, magnifying loops, bite test, dye test, wedging, transillumination, surgical assessment, CBCT, and periapical radiograph. So this is the bite test, which is also known as tooth luth, whereby the tooth luth is placed on the concerned teeth and patient is required to bite on it. While staining with dye, the crack detection is done with dye, whereby the dye makes the crack visible. Wedging and magnification is also used to detect cracks and fracture. So next is the transillumination, whereby photon is used. The fracture can be seen through the transillumination. And also next, surgical assessment, whereby a flap is raised to detect the crack line. Cone beam CT scan is also used to detect cracks in endodontically treated teeth, specifically vertical root fracture. Next is the periapical radiograph, whereby the crack line is visible in the radiograph. There are also other tests that can be done in the chair side, which are the plaque disclosing agent, mobility testing, palpation, and percussion. Plaque disclosing agent will help us to disclose the plaque, and we are able to know the old plaque, the extra high risk plaque, and the new plaque. Plaque disclosing agent are available in the form of gel and tablet. Mobility testing is also important as one of the chairside investigations, whereby the back of the mirror and also the mouth probe is used to check for the mobility by applying pressure in a horizontal manner, and the mobility is classified into 3 classes accordingly. Periapical testing is also important, whereby palpation and percussion is done to check for any tenderness that can lead us to a diagnosis of apical periodontitis. Next, we are going to look at the chairside investigations for the vascular lesions. Tests that is commonly done for vascular lesions are the diascopy, which is a test for blanchability performed by applying pressure with a finger or a glass slide and the color changes are observed. So the indication is to differentiate a vascular lesion from a non-vascular pigmented lesion. And the indicative lesions are hemangioma, arteriovenous malformation, angioma, and varicosity. In this procedure, a glass slide is placed over a suspected lesion. When pressure is applied, the lesion decreases in size and the color becomes pale, hence blanching.
Next, we are going to discuss about the investigations for oral potentially malignant diseases or ISHARD or PMD. First is the biopsy and histological examination. In this procedure, a small sample of tissue will be taken from the suspicious lesion, which the lesion will be examined under the microscope, which is the histological examination. The biopsy and histological examination, it is a gold standard for diagnostic. The second one is the toluidine blue staining. Toluidine blue staining is actually an acidophilic dye which selectively stain the acidic tissue components such as the DNA and RNA. This procedure considered to be sensitive in identifying early oropharyngeal pre-malignant and malignant lesion. Why the toluidine blue staining can detect the DNA and RNA? This is because when there is increased amount of DNA and RNA in neoplastic cells and the wider intercellular canal compared to normal epithelial cells, which are responsible for the staining to occur. The third one is oral CDX brush biopsy. It is a minimally invasive and computer-assisted sample analysis that detects the abnormal cells in all cell layers of the epithelium of the oral mucosa. The procedure can be used without any special training and can aid in confirming the nature of the potentially malignant disorder and for revealing those that are precancerous and cancerous. Next is assessment for maxillary sinuses. We are going to show two types of assessment. First is by palpation, and the second one is by transillumination, which is the special investigation. In palpation procedure, first before we assess the maxillary sinuses, we must perform a good hand hygiene and explain the procedure to the patient and get the patient's consent. Next, stand directly in front of the patient with a good lighting and begin the assessment by palpating for sinus tenderness. This can be achieved by placing two thumbs just under the zygomatic arches and press up on the maxillary sinuses as shown in the diagram, and then lightly percuss directly over the maxillary sinuses. The local tenderness with palpation or percussion associated with signs and symptoms such as fever, pain, and nasal discharge, it suggests that acute sinusitis involving the maxillary sinuses. Next is special investigation for the maxillary sinuses, which is the transillumination of the sinuses. The indication for this procedure is when the sinus tenderness or other symptoms suggest sinusitis, but the contraindication for this procedure, the technique is not highly sensitive or specific. How can we do this? First, ask the patient to remove the upper denture if the patient is wearing any denture. Next, position the patient with neck slightly extended back with mouth open and place the transilluminator over the lower orbital rim lateral to the nose as shown in the picture, and direct the light source downward towards the mouth. Observe for glow on the hard palate. When there is a dim reddish glow, it indicates that the normal airfield maxillary sinuses, which indicates that the maxillary sinuses is normal. When there is absence of glow, it suggests that there is a thickened mucosa or secretions in the maxillary sinuses, which can indicate that the patient might have sinusitis. Then repeat the procedure on the other maxillary sinus.
Now, moving on to investigation for saliva. Saliva can be collected as a whole saliva or glandular saliva. Let's start with collection of whole saliva. Whole saliva can be collected in different forms, be it resting or unstimulated whole saliva, or in another form as in stimulated whole saliva. The first and common way of collecting whole saliva is by spitting method. Saliva is accumulated in the floor of the mouth and the subject spits out into the pre-weighed or graduated test tubes. The advantages of this method is that it can be used when the flow rate is very low and where evaporation of saliva has to be minimized. The disadvantages, however, this method may have some stimulatory effect, hence it cannot be used for unstimulated saliva collection. Second is the draining method. So the subject is to sit still with his head bent down and the mouth open to allow saliva to drip passively from the lower lip into the graduated sterile tubes. The advantages of this method is that it is more reliable as the saliva is collected without any stimulation. Hence, it is used for unstimulated saliva collection. The disadvantages, however, it is quite uncomfortable for the patient. So the third method is by suctioning the saliva. Saliva is allowed to accumulate in the floor of the mouth and aspirated continuously using micropipettes, syringes, saliva ejector, or an aspirator. Finally is the swabbing method. As you can see in the picture shown, the subject is asked to chew a synthetic gauze sponge, pre-weighed swab, or cotton pad so that the sponge gets soaked within the saliva. The saliva-soaked sponge is then removed and placed in a sterile test tube. The uses for this method include to assess oral dryness and monitor the effects of drugs, hormones, or steroids. The disadvantages, however, is that it is less reliable. Now, moving on to the collection of glandular saliva, which essentially involves parotid gland, submandibular gland, and the minor salivary glands. Firstly, let's take a look at the parotid saliva collection. So the parotid saliva is usually collected using a Lashley cup, a Carlson, or also known as a Carlson Crittenden collector. So as you can see in the picture, the device is located in the buccal vestibule, or more specifically at the opening of the parotid duct. So this device is designed by Carlson Crittenden. It consists of two metal cups with two outlet tubes, as you can see in the schematic drawing. The inner cup collects saliva, whereas the outer cup is connected to the vacuum. So the basic design was modified by Lashley. So moving on to the submandibular saliva collection, it is commonly collected via the segregator method. The segregator method allows the collection of saliva from both the submandibular or sublingual glands. The device used in this method is made of metal or plastic, constructed on a stone model for each individual. The device has a central chamber for collection of submandibular saliva and two lateral chambers for collection of sublingual saliva. The collector is placed on the lower jaw and the polyethylene tube connects the chamber to the collecting tube. The disadvantages of this method is that it is time consuming since it's fabricated and adjusted individually. Finally is the collection of saliva from minor salivary glands. Saliva from minor salivary glands includes palatine saliva, buccal, and labial saliva. The palatine saliva is collected using a filter paper or a pipette method. Labial and buccal saliva, on the other hand, is collected using the perio paper or cyalo paper absorbent method as shown in the picture. The quantity of saliva can be determined by a device known as a periotron, also shown in the picture. The periotron determines the GCF volume and investigates the sample composition accurately. Now that we're done with the methods of collecting whole saliva as well as glandular saliva, let's move on and take a look at the test for xerostomia. So diagnosis of xerostomia is based on evidence obtained from 1. Patient's history, 2. Intraoral examination of the oral cavity, and 3. Cyalometry, which is a simple chairside procedure that measures the salivary flow rate. Xerostomia should be considered if the patient complains of dry mouth, especially at night, difficulty eating dry food like biscuits, sandy grainy feeling inside where they would feel a sandy or grainy feeling inside the mouth. Alternatively, xerostomia may be tested using the tongue blade sign, where you would notice a tongue depressor or a blade sticking to the buccal mucosa, or a lipstick sign, where in women the lipstick sign shows that the lipstick is adhering to the front teeth. Now, moving on to the test for taste disturbances. You may wonder, what is a taste disorder? So a taste disorder is known as the reduced ability to taste sweet, sour, bitter, salty, or umami, a condition called as hypogeusia. Some people who can't detect any taste are called ageusia. Fun fact, there is this common taste perception known as the phantom taste perception, where there would be a lingering, often unpleasant taste even though there is nothing in the mouth. There are many causes of taste disorders. So one of the examples would include a upper respiratory or middle ear infection, radiation therapy for cancers of the head and neck, exposure to certain chemicals such as insecticides and some medications including some common antibiotics and antihistamines, head injury, some surgeries to the ear, nose, and throat, such as a middle ear surgery or extraction of the third molar. Poor oral hygiene and dental problems can contribute as well. So taste disturbances are tested using the easy-to-administer tests that are available for olfactory and gustatory testing, for example, spatial tests, taste sticks, and tasting tablets. Secondly, Simple sip, spit, and rinse tests or chemicals may be applied directly to specific areas of the tongue. This is to help measure the lowest concentration of a taste quality that the patient can detect or recognize, or to compare the taste of different substances, or to note how the intensity of the taste grows when a substance's concentration is increased. Now, moving on to the test for oral malodor, or essentially known as bad breath. Oral malodor, also known as halitosis, happens when oral microbes decays and start generating volatile sulfur compounds, also known as VSC. There are many literatures that have shown positive correlation between oral malodor and presence or severity of gingivitis and periodontitis. Among the gram-negative bacteria, Porphyromonas gingivalis, Prevotella intermedia, Fusobacterium species Tenerella forsythia, and Treponema denticola are major contributors of volatile sulfur compounds. So the tests for oral malodors includes first, bacterial sampling, which by the way is the gold standard. The bacteria is sampled from the gingival sites for anaerobic culture. Secondly is through organoleptic scores. So the scores include a scale of 0 to 5. And thirdly is the breath checker, where it is used to detect the volatile sulfur compounds and hydrocarbon gases in expired mouth air.
Next, for allergy, atopic disease and related allergies, such as asthma, eczema, some drug reactions, contact dermatitis, latex allergy, and allergy to mercury and other metals. Dental allergies. Some of the type of dental materials associated with allergic responses are base metal alloys containing nickel and gold alloys, which are used in the construction of crown and bridge, dental amalgams, where the patients may have rare reaction to the metal in the amalgam or have a family history of metal allergies, and also acrylic or denture reline materials. The dental products associated with allergies are toothpaste or mouth rinses containing sodium lauryl sulfate. Sodium lauryl sulfate can irritate the soft lining of the mouth and cause sloughing of the surface epithelium of the oral tissue. Patients often describe this as a slimy feeling in their mouth when waking up in the morning. The treatment is discontinuing the use of sodium lauryl sulfate containing products and monitoring the patient. Toothpaste and mouth rinse containing natural flavoring agents such as cinnamon can also produce rash-like reactions on the oral tissue. Whitening or bleaching agents, the overuse of it can cause adverse rash-like irritant reaction to the gum and oral tissues. It can also damage the teeth by demineralizing the enamel. Next, medication-related allergies such as antibiotics, for example penicillin, tetracycline, and sulfuric drugs. The most common drug allergy is the allergy to penicillin. The signs and symptoms include rash, hives, and life-threatening anaphylactic reaction that causes difficulty in breathing. For patients with allergy to penicillin, the drug of choice should be erythromycin. Some patients may also have allergy to topical and local anesthetics containing benzocaine. The reactions include syncopal episodes, cutaneous reaction, and airway compromise. So the dentist need to avoid using any topical and local anesthetic agent related to benzocaine in patients with this allergy. For asthma-associated allergy, we have to get a complete family history, such as whether their family members have asthma, environmental and occupational history, such as hazards like the biological enzyme, plastic, or dust, and also a medical history such as whether they are on aspirin, as those can relate to asthma. For the investigation, a skin prick test should be performed in all cases of asthma to help identify the allergy cause. Lung function test will show variable airflow limitation. Sputum test, where presence of large number of eosinophils in the sputum is a diagnostic tool. Tests for allergies are blood tests, which measures the level of IgE antibodies to specific allergens in the immune system. Skin prick tests, where a small amount of possible allergen will be pricked on the skin, and if the skin becomes red, swollen, and itchy, the person may have an allergy. Patch test is to check for contact eczema, where the doctor may tape a metal disc with a small amount of suspected allergen to the person's back. Any reaction will be checked after 48 hours and then again after another 48 hours. Contact dermatitis is a common inflammatory skin disorder. It's most commonly known as eczematous inflammation. It's an allergic or irritant skin reaction caused by an external agent. It can be classified into two, which are allergic contact dermatitis and irritant contact dermatitis. Allergic contact dermatitis is a type 4 cell-mediated hypersensitivity reaction, and irritant contact dermatitis is due to prolonged and repeated exposure to irritant. Inflammatory cells have a role in developing dermatitis. The investigations are patch test, skin biopsy, dimethyl glyoxam test for nickel. Next, for latex allergy, which is the main allergic disease affecting healthcare workers. The necessity for gloving for all clinical work has resulted in a growing frequency of latex allergy. Patients exposed to latex through medical procedures are also at risk. The individuals at risk of latex allergy are healthcare professionals, atopic patients, spina bifida, urogenital anomalies, latex industry workers, and those subject to multiple surgical procedures before the age of 7 years old. Investigations are history taking, blood testing, where increased level of serum tryptase demonstrates the mast cell activation with mediator release has occurred. Serology testing, where measurement of serum-specific IgE antibody to latex is taken. Skin testing, which should be performed after 4 to 6 weeks after the anaphylactic episode because of the mast cell mediators depletion. It is done by placing an allergen solution on the skin, and if it's positive, the skin becomes red and itchy. Lastly, for allergy to mercury and other metals, the main source of reactions are mercury in amalgam and nickel. Mucosal reactions such as lichenoid-type lesions have been reported, but evidence is conflicting as to whether these are true allergic reactions. Amalgam loss in the submucosal tissues frequently do not cause any reaction histologically. Nickel allergy is a less common source of allergic reactions. It may be present in bridge and crowns. Even in patients allergic to nickel, a nickel-containing appliance may cause no reaction in the mouth, but it may affect the skin. The dangers of mercury are either from systemic absorption, particularly of organic mercury compounds such as methylmercury, or from the development of hypersensitivity. Systemic mercury toxicity is another possible occupational hazard of dentistry. Side effects of mercury are allergy. The antigen-antibody reaction marked by acute reactions such as itching, rashes, or sneezing. Contact dermatitis and type 4 hypersensitivity reaction is the physiologic side effect of amalgam. Toxicity depends on amount of exposure, length of exposure, amount of mercury accumulated in the body, and overall health of the patient. The mercury symptoms in the oral cavity are bleeding gums, alveolar bone loss, loosening of teeth, excessive salivation, foul breath, metallic taste, burning sensation, tissue pigmentation, stomatitis, ulcerations on the gingival palate and tongue. For investigation that can be done is the skin patch test, which will indicate a very strong reaction to mercury.
So I'll be talking about neuromuscular diseases. The first disease is Sjogren's syndrome. Sjogren's is a systematic autoimmune disease that affects the entire body. A few of the general manifestations of this syndrome are extensive dryness of eyes, profound fatigue, chronic pain, major organ involvement, neuropathies, and lymphomas. One of the oral manifestations is dry mouth. There are a few investigations that can be done. The first one is blood test. This is to detect specific antibodies that may signal autoimmune diseases. The antibodies associated with Sjogren's include anti-RO-SSA, anti-LA-SSB antibodies, rheumatoid factor, anti-nuclear antibodies. The second investigation is cellometry. It is a non-invasive test used to measure how much saliva is produced. Normal salivary flow is between 1 to 2 ml per minute, but in Sjogren's, it may be reduced to 0.5 ml per minute or less. The third investigation is Schirmer's test. This is to determine if tear glands produce enough tears to keep the eyes adequately moist. And it is also to confirm and determine the severity of dry eyes. So calibrated strips of non-toxic filter paper are used. Wetting of less than 5 mm is indicative of deficient tear production. The fourth test is salivary gland biopsy. Histological changes in salivary gland that can be seen are polyclonal infiltration, mainly by CD4 lymphocytes, infiltrate initially periductal, progressive spread of infiltrate through the glandular tissue, progressive destruction of secretory acini, proliferation of some duct tissues as epimyoepithelial islands. So this is the histo of the biopsy. So the second disease is systemic lupus erythematosus. It is an autoimmune disease in which the immune system of the body mistakenly attacks healthy tissue and can affect the skin, joints, kidneys, brain, and other organs. Joint pains and rashes are most common manifestations, but with the classical picture of young women with a butterfly rash across the mid-face is uncommon. About 20% of the patients with SLE develop oral lesions. These somewhat resemble lichen planus but may not respond to the doses of systemic corticosteroids. So these are a few symptoms of SLE. For investigation, the first one what we can do is blood test for anti-nuclear antibody. The most important of many autoantibodies seen in SLE are anti-nuclear factors. Only antibodies against double-stranded DNA, anti-dsNA, are peculiar to SLE. The third disease is systemic sclerosis. This causes subcutaneous and visceral fibrosis, which leads to stiffening of the skin. The oral manifestations include Sjogren's syndrome, limited oral opening, widened periodontal ligament shadow, gross resorption of the jaws, firm whitish yellow fibrotic mucosal plaques. For investigation, laboratory studies, a rapid increase in serum creatinine levels, increased serum level of muscle enzymes. For autoantibody assays, anti-nuclear antibodies present in 90 to 95% of affected patients, topoisomerase 1 antibodies present in approximately 30% of the patients, anti-RNA polymerase 1 and 3 are present in 15 to 20% of patients affected. So moving on to digital microscope and slide scanner. For introduction, a digital microscope is a unit that makes use of optics and a digital camera to process an image and transmit it to a monitor, which can be a computer or an iPhone or an iPad that runs specific compatible software. A digital microscope can be achieved by integrating a camera into a microscope or by adding a digital microscope camera to a regular microscope. An external digital microscope camera leads to greater flexibility. You can use different cameras on the same microscope and vice versa. Most digital microscopes and microscope cameras include basic image capture and documentation software, while slide scanner stimulates the experience of a light microscope and allows viewing of digital slides over a broad range of magnification that allows review, interpretation, and subsequent diagnosis of a digital surgical pathology slides, which is also called telepathology. So these are the parts of the microscope. We've got focus roller, magnification ratio, LED light, snap, USB line, and finally the metal fixed stand. So these are a few examples of the slide scanner. For function-wise, a slim tool that can be easily used in different fields including microbiological observation, which is also called telepathology, educational purpose, skin examination, textile industrial for textile inspection, printing inspection, industrial inspection, PCB, precision machinery, hair examination, jewelry and coin collections inspection, and also visual assistance. So there are a few advantages and disadvantages of digital microscope. LED lights, which when switched on, it enhances the clarity and brightness of the specimen being viewed. However, in absence of an eyepiece, the image is focused on a digital circuit and has to be viewed through an external monitor to which the microscope is attached. The entire system is thus adjusted with a monitor image, and the optics for the human eye to directly view the specimen is totally eliminated. Digital USB microscopes were invented with exceptional image quality and magnification that were much cheaper when compared to the traditional microscopes. Digital microscopes have high-resolution image output that can be recorded directly onto computers or iPhone. The image quality of microscope is sharp and clear. Whole slide imaging systems that are able to convert static microscope images to virtual digital slides. Scanned digital image allows viewing of more slides and consequently more tissue simultaneously. Possible to move the slide in any direction, focus the image, and alter the viewing magnification. Some systems are able to manage large format slides and consequently will have increased scan times. Many computer systems often struggle to compete for digital file storage. That's all for our presentation. Thank you.